one is the kidney transplantation. However, despite low rejection rate of grafts in the low-risk setting is 12%, but rejection can be high to 70% in high-risk patients. What is the risk factor of corneal graft rejection? The first one and the most important one is the presence of stromal blood vessels in one or more quadrant in the recipient cornea, prior graft rejection episodes, perioperative glaucoma, prior anterior segment surgery, active ocular inflammation, ocular surface disease, herpes simplex keratitis, neurotrophic keratopathy, and anterior synetia. All these are the risk factors for corneal graft rejection. But the most important, as I said, is the corneal vascularization. The presence of stromal vascularization in all four quadrants doubles the risk of rejection. The corneal vessels in a patient May rejection rate is 40% in the first trial of implantation. If you did the second graft, it will increase to 60–80% rejection. And the third one, really, it's 80% rejection rate. What is the type of rejection? All of us know the types, the main classical type, the epithelial one, the stromal, and the endothelial with the codest line. But also there is another is subclinical rejection. This with the time, you will notice in this picture the endothelial cell count after 27 months of transplantation. After 30 months, there is increase in the size of the endothelial cells and decrease in the number with infiltration with lymphocyte and neutrophils in this picture. So it will decrease the haze. The haze will increase in the graft and the thickness will be increased with the time. This is called subclinical rejection. What is the therapies for corneal graft rejection? It's the immunosuppressant. The most important one is the steroid. The topical steroid are the mainstay of treatment and the management of autograft rejection and post-operative prophylactic therapy in high-risk patients. For the non-endothelial graft rejection, topical steroid, it could be used 6 times per day or increased to hourly with bedtime ointment of steroid. But with the patient with a risk of increased intraocular pressure, we should use the synthetic analog of corticosteroid lotopridol, which have less significant increase in intraocular pressure and the cataract formation. For how long we're gonna use this medication? Topical steroid. Nagwan did a nice study, prospective randomized 406 eye after 6 months after PQB and topical prednisolone acetate 1% to either stop or continue. There is 2 groups to continue after 6 months or stop at 6 months. He found that 9.1 rejection in the non-steroid group who stopped at 6 months and 4.9 in the long treatment group for 1 year. So we prefer to continue for 1 year in these patients. Systemic steroid in an randomized also clinical trial that evaluated the outcome of topical corticosteroid therapy 60 to 80 milligram oral methylprednisolone daily or single intravenous 500 milligram methylprednisolone. They observed that the pulse therapy is superior. We'll ask ourselves why? What's the difference between the steroid orally and the steroid IV? The main cells responsible for rejection is the T and B lymphocyte. By the oral steroid, it will decrease the function of these cells only. But with the infusion of methylprednisolone, it will kill the T lymphocyte. So you have the chance to decrease the rejection rate. So it's preferred to use only the methylprednisolone infusion in this case. What is the other medication after that? Cyclosporin A and tacrolimus is a calcineurin inhibitor. And it's very important to know some notes about this medication. Benefit of combination therapy with topical steroid and topical cyclosporin, we are using it in some cases. But there is a mixed and controversial about the benefit of this medication topically. For the patient on whom corticosteroids are contraindicated, we can use the topical cyclosporin 0.5%, provide an effectuous and alternative for the post-transplant management with maintenance of graft clarity. So we can use it successfully topically with cyclosporin in risky patients who develop intraocular pressure with the steroid. The most common medication is cyclosporin orally. We are using the most common medication in the market is the new oral or Sandimmune. And this medication with many forms, 25, 50 milligram, and 100 milligram capsule. The systemic administration proved is more effective in the management of high-risk patient after transplantation. And really, this is the medication we are using extensively. But we should look for two things: the systemic blood pressure, because it increases in significant number of the patient, and also look for the CBC and the kidney function. If the kidney function is triple, stop medication, skip dose, and you can adjust another medication after that. The other medication is tacrolimus. We can use it 2 milligram or up to 12 milligram daily, and its benefit in preventing and treating graft rejection in high-risk patient with graft survival rate 6 to 5%. But this medication have high incidence of malignancy formation, especially topically type. The antimetabolite like mycophenolate mobile, which is called Silicet in our market, is an inhibitor, inosine monophosphate dehydrogenase, inhibits the de novo synthesis of DNA in T and B lymphocyte, making these immune cells is cytostatic. So it will stop the function of T and B lymphocyte and decrease the rejection rate. In a randomized clinical trial, they compared between the Silicet and cyclosporin, but they found that the Silicet is higher. It's called the mycophenolate mobile is higher and effective and better than cyclosporin, which we are using, but it's high price medication. It's a short lecture, so I'm gonna say the home message. In case of severe industrial graft rejection, please use intravenous pulse 500 milligram prednisolone instead of oral type. Consider evidence exists that the systemic treatment with immunosuppressive like cyclosporin and tacrolimus was significant and benefit for the high-risk patient. It's as a prophylactic, not the treatment. The rejection, the treatment of choice is a steroid. And the second thing, continuous suture induced inflammation as induce the parallel growth of the blood vessels and lymph vessels into the cornea. It's called lymphogenesis, so it's preferred to use interrupted suture in a patient with high risk rejection, better than continuous suture, because the cells of T and lymphocyte go through the tunnel with this continuous suture from quadrant to the other quadrant, so increase the risk of rejection. The last thing, subconjunctival injection of bevacizumab increase the graft survival rate, deliver prior to transplantation. Also regress the blood vessels and lymph vessels during graft rejection in high-risk patient, and could be injected periodically according to the severity of the vascular. Thank you.
Thank you, Dr. Alaa, for being stick to the time.